Good morning, good afternoon, good evening, everyone, wherever you are around the world, and welcome to our Global Symposium on Headaches, Understanding and Managing 21st Century Headaches in the Community. Next slide, please. Today, I'll be your moderator. My name is Parisa Aslani, and I'm a professor in Medicines Use Optimization at the University of Sydney School of Pharmacy. I'm also the Deputy Head at the School of Pharmacy as well. Currently, I'm one of FIP's Vice President and Co-Chair of the Working Group on Patient Safety. I'm also the immediate past President of the Health and Medicines Information section of FIP. My role is as researcher and educator in the area of medicine information and adherence at the University of Sydney. Next slide, please. Just a few announcements before we begin. This webinar is being recorded and live streamed via YouTube. Additionally, it's being simultaneously translated into Czech and Hungarian, and you can use the interpretation button at the bottom of your Zoom in order to listen to those languages. The recording will be available on our website at theevents.pip.org. And you may ask questions using the question box provided, the Q&A. Please use the chat just for hellos and the Q&A for any questions for the speakers. And all questions will be answered at the end of panel discussion. You're also welcome to provide feedback to webinars@fip.org. And of course, if you're not a member, do become a member of FIP. Next slide, please. Importantly, we'd like to thank Sanofi for supporting this online event and making the participation of Professor Goadsby possible. Next slide, please. So today's program, we have three speakers. The first speaker will be speaking to us about understanding 21st century headaches and their impact on patient well-being and quality of life. Second speaker will be speaking about the lived experience of headaches, needs and expectations from healthcare professionals. And our third speaker will focus on headache management in the community, the role of pharmacists in enabling empowered self-care and inpatient triage. And finally, we'll have the panel discussion and Q&A before the conclusions. Next slide, please. The learning objectives for the session are illustrated here, and by the end of this session, you'll have an understanding of 21st century headaches and their impact on patient health and well-being. Additionally, you'll have an understanding of patients' expectations from pharmacists in addressing headaches, and you'll be able to demonstrate the role that pharmacists can play in enabling self-care of headaches. So here are our speakers, and we will move on to Peter Goadsby first. Our first speaker, Professor Peter Goadsby, is Professor of Neurology at King's College London and Director, NIHR Wellcome Trust Clinical Research Facility at King's College London. He is a Professor of Neurology in the Department of Neurology at the University of California, Los Angeles, and he's also an Honorary Consultant Neurologist at the Hospital for Sick Children, Great Ormond Street, London. So please join me in welcoming Professor Peter Goadsby as our first speaker. Thank you.
Thank you. And let me thank the organisers for arranging, facilitating me speaking to this group. It's not the usual group that I would speak to. I'm a neurologist interested in headache disorders. Some time ago, I became interested in the question of how the modern environment is influencing headache and how its optimal management would maximize patient well-being and quality of life. In the next slide, I want to just outline some of the most important thing, well, the starting most important thing that kicked the process off. If you're a physician, then you're constrained by, particularly in referral practice, you're constrained by who comes to see you. And when you look at the global data, it's very clear that most people don't come to see us. In fact, about only 10% or so of patients with headache will actually seek specialist care, which is usually neurologists in most places of the world. About 20% will seek care from their primary care doctor. Remarkably, at least half of patients, according to the WHO, will actually self-treat. What we've started to call that is, not very creatively, I'm responsible for saying it, is non-doctor headache. It's the largest group of people with primary headache disorders, and they're pitching up in the largest measure into pharmacies. And that's why it's actually important to have this sort of interaction. It's estimated that more than 80% of patients who have tension-type headache just never consult a doctor at all. There are some differences around the world in cultural terms, and the data we've looked at has included the UK, France, Germany, Brazil, Japan, and Australia. And there are some interesting differences as you dig into countries. The crucial aspect, I think, is to remember, particularly as a physician, that most people who have a headache problem that they want to treat don't come to see a doctor. In the next slide, there's some data again from the WHO, which looks at at where patients are having their treatment and what the regional differences are. So if you look at, again, primary headache disorders, about 50% of patients globally are self-treating. It puts it in perspective for me as a neurologist to see that only 10% of patients are coming to see us. Well, it's not surprising. Neurology is not that common. And it varies greatly, down to 5% in Africa, as much as 20% in Europe, but still, that means 80% aren't. Patients go to see primary care physicians. As you see, that's in around 20 to 30% across the world. Alternative practitioners, acupuncture, naturopathy, and physical therapy are the three most common things that are used. There is a vast group of patients who are coming, and they're coming largely to see pharmacists. In the next slide, what you see is a breakdown of the types of headache that we're talking about. Now, tension-type headache, which is a headache that comes and goes, it's dull and bilateral, and patients aren't sensitive to light or sound. They don't have sensitivities, so to speak, is the larger group, although migraine is the more disabling group. Migraine is one-sided, throbbing pain, aggravated with movement, and with sensitivities, nausea, light, and sound. Think of migraine as headache plus, and think of tension-type headache as just headache without anything else. The other problem that's clearly common, and these are the top headache problems that are mentioned by the global burden of disease, is medication overuse headache. The concept that if one's using simple analgesics like paracetamol, for example, or prescribed medications like triptans, and sometimes over-the-counter, as opioids are codeine, can be 10 days or more a month, you can make things worse. This is the person who's buying several boxes of their codeine-containing analgesic and very often using them daily. What is clear from the global burden of disease data is that these problems are becoming more recognised. I don't want to say that they're increasing, but they are increasing by counting. I think there may be an awareness problem, an awareness issue, and as we get better at recognising the disorders, then these data are increasing. You see 15 to 19% over that decade. And I think much of this is ascertainment. In the next slide, what I think is clear is that pharmacists play a really important role in terms of giving advice to patients. if they have the time, it's very useful for them to be looking at the characteristics of the pain that I just described and any concurrent medical problems. And very often in the local pharmacy, the pharmacist will be aware of everything that the patient's taking. Hopefully they're getting all their medicines from there, and that's very helpful backgrounding. It's useful to discuss what's going on, to make a patient understand what they might expect for pain relief, and to be sure that they use a dose that's appropriate for them and for their weight. And if they're too frequently using these medicines, that they then need to be moved on into medical care, to be thinking about prevention, for example. It's really important that patients don't just get stuck in this cycle of taking these medicines without anyone reviewing the situation in case the evolution of medication overuse headache occurs. Now, in the next slide, it's worthwhile looking at disability. I mean, why talk about headache disorders? Because they're highly disabling. If you look at the global burden of disease, again, this is World Health Organization information. Headache is right up the top of the leading causes of years lost to years lived with, and therefore lost to disability. Importantly, OTC medications form part of the management strategy in this context. When you look at it, migraine itself is the number 6 or 7. It's up the top, in the top 10 causes of disability. For the under 50s, it's actually the top cause of disability. Worrisome thing is the increased levels of medication overuse headache that have occurred since 1990. You see that data from, again, the Global Burden of Disease study. Some part of that, I suspect, again, is recognition of the problem, and some important part of it is actually that the problem is getting worse. There's an enormous opportunity for pharmacy to interrupt this cycle of worsening with good advice about frequency of use and appropriateness of dosing and medications for headache disorders. In the next slide, there's summarised here which might say the interactions between the 21st century and headache. I don't know that one of my co-panelists will be revisiting this shortly. We have the lifestyle issues, whether increased technology use, posture associated with it, relative physical inactivity, stress, sleep disturbances. These are a modern lifestyle pandemic, you might say. And of course, the pandemic itself that reinforces much of these. And the fact that we're having this webinar, and the number of webinars we've spent doing in the last 18 months will tell you something about technology use. Now, pain itself and the headache disorders have both an impact on patients, and I think one of the impacts that's been underappreciated, and certainly something that we're all very interested in the headache field, is the problem of mental clarity, cognitive function. Patients will very often describe the problem of brain fog. The wheels just don't turn over normally. Reduced concentration, problem solving, perception, coordination, motivation. The general reduction in ability to interact with the world can be very disabling for patients with headache disorder problems. Something to be aware of. Now, socioeconomically, of course, there's a huge impact of headache disorders. There's individual reduced productivity. There's the reduced, not just the social interaction, but also interaction with community. Less involvement means less of the wheels of the economy turning around. Absenteeism from work, or presenteeism, those that go to work and don't and can't fulfill their job in its entirety. This, of course, can lead to impairment in education and in career altogether, which added up means that the person with a headache disorder is constrained and significantly disadvantaged. And while it seems like a huge picture problem, the simplicity of it is that if we get the management right, things can improve right across the board for the patient and for the community. Now, in the next slide, it's some comments about trigger management. Trigger management has been quite a vexed issue over the years, and I think that electronic diaries are enabling us with these apps are enabling us to get a better grip on what's going on in the real world, in where the patients are treating. One study of tension type headache in China was reporting 2/3 of patients with trigger factors, sleep disturbance, mood change, and light exposure. Other important triggers that are unsurprising, perhaps too, stress. Patients with migraine will report not only stress, but the reduction in stress. And in fact, often the reduction in stress is the letdown phenomenon, is a more reliable trigger. Changes in routines, dehydration, certain foods, that's a very complex area. Alcohol, travel sometimes, particularly time zone changes, altitude change certainly. Some aspects of exertion, maybe over-exercise. Some patients will find particular postures that are troublesome. The advice of regular sleep, regular meals, regular exercise, or regularity to life is not that easy in the 21st century, and so makes it difficult for patients who are prone to headache problems to be able to get a grip on the problem, you might say. The comorbidity, of course, of tension type headache, moving from the episodic version, less than 15 days a month, to the chronic version, is again importantly associated with medication overuse. And so that's something to be aware of in patients who are coming in with an apparently simple and benign problem seeking medications. In the next slide, is talking about some real world evidence using headache diaries, patients answering questions about their headache in the Migraine Buddy app, 15 questions when registering an attack. This is data that came from more than 60,000 users, and you see 5 countries really getting around the world, so to speak. So in the next slide, we'll look at some of the data. And what we'll see is the number of episodes per month, the variation with countries by colour. You see that migraine is, unsurprisingly, in an app called Migraine Buddy, perhaps is the more common problem. And I think that it's well accepted. It's certainly the more disabling problem. You see the variability across countries in terms of frequencies of headache. And I think I'm more struck by the similarities than the differences. There are subtle differences, but it's certainly clear that the typical headache sufferer is having up to 4 attacks a month. They largely don't need prevention. Most of these patients, these folk, need good acute management. And in the first instance, they're going to be pitching up to the pharmacy. Now, clearly the people at the right side, the far end, having more than 5 and people having more than 10 attacks a month, need preventive strategies. They need referring on. They're red flagging, you might say. But the majority of patients, you can see, even in this app dedicated to migraine, are in a group that need acute attack maximisation. They report the impact on their daily life, missed work, social activity, family time, school. Headache disorders don't shorten life, primary headache disorders. They ruin days. They steal people of the active days of their life that they're not going to get back. You don't bank them and get them back. So the functional aspect, the ability to improve function, is the important role for pharmacy, for medical practitioners to optimise what a patient could do with their life. Patients are reporting in this study the impact of vomiting, slowing up at home and at work, having trouble with sleeping, difficulty concentrating. Again, going back to those to that theme of brain fog, which is really very troublesome. And these data have been very helpful in getting a grip on the size of the problem and looking at patients in their own bailiwick, you might say, where they live to understand the issues. Now, in the next slide, there's some discussion around the management, particularly of tension-type headache. This is largely taken from a recent review of Sadashina and, of course, the data from the WHO World Headache Atlas. It's well accepted that education and trigger management are the bedrock of headache disorder management, whether it be tension-type headache or migraine. And for tension-type headache, moving to symptomatic management with aspirin, acetaminophen/paracetamol, or combination treatments, including non-steroidals. Preventive treatment, the non-pharmacological treatments in tension-type headache, particularly physical and occupational therapy, acupuncture, and pharmacological therapy, for which there are very few in tension-type headache. And once you get past the amitriptyline, mirtazapine, venlafaxine, it gets very, very, very woolly in terms of therapies. Now, different parts of the world, different analgesics have their flavour, you might say. In the world generally, you see that about 70% of patients using paracetamol/acetaminophen, aspirin about 50%, and about 90% are using a non-steroidal. And you see the variability with that when you look at the Americas and Europe and Western Pacific. But broadly speaking, those numbers seem to be largely similar, with the exception of the Americas for paracetamol. Non-steroidals are very popular, and their careful use is clearly something that patients think is important in their management. Now, in the next slide, that brings us to the more recent interaction of the pandemic with a certain element of hysteria, you might say, around the use of, around particularly the use of non-steroidals. The fact that SARS-CoV-2 hooks onto angiotensin-converting enzyme 2 to gain admission to cells caused a bit of a stir, you might say, in the early days of COVID, in thinking about whether non-steroidals would be problematic in COVID. Certainly in the headache world, we're used to using ACE inhibitors and angiotensin receptor blockers, the candesartan, for example, as migraine preventives. And we're well aware, tension-type headache and migraine, of the use of non-steroidals. Ibuprofen in particular came in for a little bit of a hammering. It's quite clear and widely accepted from the range of groups that are there, and I'll particularly highlight the World Health Organization and the European Medicines Agency. There's just no evidence that ibuprofen impacts on the COVID-19 SARS-CoV-2 infection, and there's no rationale for what was the, might say, panic buying of acetaminophen/paracetamol in 2020. It's most unfortunate, and the discussions that we had with patients, reassuring them that they could stay on their, particularly their angiotensin receptor blockers for migraine and indeed for hypertension, was a conversation that we had very often in the early days. Thank the Lord that the science and the pharmacology pushed that back into its box where it belongs. In the next slide, let me just summarise some recent developments in this area. Self-management, of course, COVID and e-commerce. You don't have to be a lecturer to realise that COVID has been a growth area for e-commerce, and that's not surprising. Initially, there was a stockpiling of OTCs for the pandemic, and certainly the pandemic's boosted e-commerce. Online spending has just risen astronomically, and what happens in the medium term, I don't know. You'll be better placed to know than I will what's going to happen. I don't think when things are open up, that people are going to stop going to see their pharmacist. How they buy things is of course an open question. What are the trends? Higher dose non-steroidals, combinations, smaller pack sizes I see, and these combinations growing in popularity. At the end of the day, patients are going to come and see pharmacists for headache disorders. Most of them will have tension-type headache or migraine. The most disabled ones will have migraine, headache with other features. The others will have tension-type headache, just headache, no other features. Helping them and advising them to carefully use over-the-counter medicines, not to use them too frequently, and to optimise dosing and their use so that patient disability is minimised is one of the great opportunities of pharmacy in the 21st century. Clearly, neurology and the physician world is in the minority when it comes to managing these patients. And the more that we can partner in the physician world, both neurology and general practice, with pharmacy to optimise outcomes for patients, the better it will be for the patients and the better it will be for the community. So I'm very grateful for the opportunity to speak to you, and I look forward to listening to my colleagues and then look forward to the panel. Thank you.
Thank you very much, Professor Goadsby. That was a very informative session. We've got questions coming up, but we'll hang off to them until our panel. Thank you very much.
Thank you.
We now move on to our second speaker, Kerry Smart, who's a writer and a patient advocate, and who has been a sufferer from chronic migraine for the last or more than 30 years. In 2005, Kerry started the Daily Headache. She has also started other writing, including the migraine.com since 2011. Kerry's a CHAMP participant and has worked with a number of patient advocacy organisations. She's also a patient advocacy consultant. Please join me in welcoming Kerry Smart to speak to us on her experience as a patient advocate. Thank you.
Thank you for that introduction. I'm excited to talk with you today. Next slide. I was invited to speak with you to talk about the lived experience of having a headache disorder. I struggled a lot with what I was going to talk about because I have had severe chronic migraine for most of my adulthood. So I knew I could tell you about the number of times I cried myself to sleep because I literally did not know how I was going to have the energy to get through the next day. Or I could tell you about the night that I dragged myself across the living room floor on my belly because it hurt too much to walk or even crawl. It took me 45 minutes to move 20 feet because I had to pause so frequently because I was just so worn out. These are vivid, memorable experiences, but I don't think they're representative of most of the people who are coming to talk to you about headache or even migraine. And I was thinking about the people who are likely to come to you and realize that there is a portion of my story that is similar, is relatable. And that is, I wasn't diagnosed with migraine until I was 25. Before that, I thought I had headache. I've had headaches basically my entire life. They got worse around puberty, but I was able to function pretty well and had a pretty normal adolescence. If the pain was mild, I'd be able to go to school and then go to theater rehearsal and get through, until 10 o'clock at night And I might be a little extra tired on those days, but for the most part, it just didn't have that much impact. On days when the pain was more severe after school, I'd take an over-the-counter analgesic, and then I'd go to the journalism room and get the newspaper ready to go to print. And again, get home late at night and was basically fine. But of course, I wasn't actually fine. I was able to function, but ultimately I had this migraine disorder developing in the background. And so I began to wonder, what if I had gone to a pharmacist when I was 16 and said, hey, I have these headaches. They're not too bad, but they're really kind of interfering with my life. What could a pharmacist have told me? And that's what I'm going to talk to you about today. Next slide. You have a lot of opportunities to help. And in all of these opportunities, I think the most important things to keep in mind are that patients need you to listen to us and believe us. I think if you're at this webinar, you understand how important that is, but headache and migraine both are stigmatized, they're dismissed. People say, oh, that's just a headache, take medication and get over it. But if somebody's talking to you, then it's likely that they can't just take medication and get over it. So please listen to us, believe us, and know that both headache and migraine can have the brain fog that Dr. Goadsby mentioned. And so we might not be communicating very clearly. And so keep that in mind as you're speaking with us. Next slide. So trigger identification is the first topic that I want to talk about. And I brainstormed some potential triggers. Let's start with the list: stress, screen use, diet or skipped meals, sleep issues or disruptions, dehydration, exercise, muscle tension, caffeine withdrawal, alcohol, and medication changes. All of these things that I've mentioned can be addressed with lifestyle management, basically, or simple behavioral or medication changes. Some need more complicated intervention, like sleep issues, sleep apnea can be a trigger. And so obviously that needs seeing a physician and getting help, getting that addressed. But this is only a short portion of the potential triggers. It's what I brainstormed off the top of my head. And so there are many different possibilities of things that could be triggers for people. I included in the footnote a link to SEEDS, which is a lifestyle management program. It's specifically for migraine, but many of the changes can be made for headache as well. And so in some of these triggers, like stress, that obviously stress is a big thing, generally not fairly easy to manage. But there are tools that people can use to make it easier to manage, like biofeedback, mindfulness-based stress reduction. That's usually like an 8-part course. And once somebody takes that course, they can learn the tools to manage stress better. There are meditation apps that can make a difference. If skipped meals is a trigger, then somebody can learn to carry a snack and set an alarm at meal times and think, well, if I'm not about to eat, then I can eat this handful of almonds, and that can manage the trigger. Or muscle tension, like workplace ergonomics can help with that. Stretching, maybe massage. So there are a variety of interventions for different triggers that can make a huge difference in people's lives. I know that you probably don't have time to talk to everybody about all of the potential triggers and all the potential solutions. But what you can do is have people keep a headache diary, which Dr. Goadsby mentioned. This can be done in an app. It can be done just on a piece of paper. I like to print out a calendar page. That way I have an at-a-glance look. And the more detailed, I feel like people tend to go for a more detailed headache diary because they want all of the information. But with more detail comes the greater risk of just not keeping up with it. So what I recommend for a headache diary are to include the date, the time of onset and duration, pain level, medication taken, and notes on suspected triggers. Now, the reason I say suspected triggers is that most people think that they know what is triggering their headaches, or they have some vague idea. But it's really easy to misattribute triggers. It's like we look at the big shiny thing and think, oh, that must be it. And maybe it is, but maybe it's not. For example, my migraine attacks got worse during last year, and I considered all the possible triggers and decided that it probably was stress. I couldn't come up with anything else. And it seemed a little strange because stress isn't a major trigger for me, but it was 2020. And so it kind of made sense. And I made some changes and tried to manage my stress better. And it kind of seemed to help, but not really. And 10 months in, I discovered that I actually had a protein deficiency, and that was the trigger. That's not a common trigger, so not something that you probably need to look at for most people, but that's just an example of how easy it is to misattribute triggers. Next slide. Supplements. So up to 82% of patients have used complementary or alternative medicine for headache or migraine. And I say up to 82% because I say up to 82% because that's all modalities, not just supplements, but it shows an interest in these particular modalities or treatments. Supplements are used prophylactically, which is really great because the best treatment for headache is to keep it from happening in the first place. That can be done with trigger management. It can also be done with supplements. And you may be wondering who's a candidate. What I tell patients who are asking me for advice is if they feel like their headache or migraine attack is interfering with their lives, then they're a candidate for a supplement. Sorry, they're a candidate for prophylaxis. So it might be that they need to see a physician for preventive treatment, but there are a lot of preventives that are available that can be effective that don't require seeing a physician, which is why I'm talking to you about supplements. The other guideline I use is that if somebody is averaging 2 or more headache or migraine days a week, I recommend that they consider some sort of prevention. And I'll get to that in a moment, for the reasons why for that in a moment. But if somebody doesn't really feel like it's interfering with their lives, then it can be hard to convince them that they need to take a preventive. But it can be super important. The commonly recommended supplements, I'm not going to go through all of these. I'm not a physician, so I'm not going to give advice on them. I've included in the footnotes a couple links, a couple articles that you can take a look at. A couple of things I want to note. If you recommend magnesium, please recommend one of the forms that's more bioavailable and easily digested because it can cause GI issues. If somebody is going to take magnesium and get diarrhea, they're not going to keep taking it. And so they're not going to get the benefit that it could have for their headaches. And then the other point I want to make is that most of the research for supplements is for migraine specifically. There are some on tension type headache for children or adolescents, but you won't necessarily know what headache disorder, if even somebody has a headache disorder when they're coming to talk to you. And about half of people with migraine are undiagnosed. Dr. Goadsby addressed how many people are untreated or don't see a physician or self-treat. But I think that point of half of people with migraine are undiagnosed is big. And so many people I know with migraine think they just have headaches. They're not aware of the other symptoms, even when they're happening in their body. So that's something to keep in mind, and use your professional judgment and consider what the risks are for the supplements and if they could potentially help the person that you're talking to. Next slide. Another opportunity that you have is medication overuse headache. Education about medication overuse headache. Patients call it rebound headache, and it is where the medication itself actually causes the headache. Somebody starts taking the medication for headache and it helps. And then over time, the medication itself is actually what's causing them to need to take the medication for headache. As Dr. Goadsby addressed, the over-the-counter medications that can have issues with medication overuse headache are analgesics taken 15 days a month or more, or triptans or opioids. I forgot that opioids are over-the-counter in some places. Those taken 10 days a month or more. Next point. So susceptibility. you may hear this and think, okay, everybody who's coming to you is susceptible to medication overuse headache. And that's not the case. We don't entirely know the susceptibility. We know it's a secondary headache disorder. So it occurs in people with primary headache disorders, generally migraine or tension type headache. But again, you may not know what headache disorder somebody has or if they have a headache disorder at all. And even in those subsets, not everybody is susceptible. And so you might think, well, maybe this isn't that big of an issue. I actually err on the other side. I treat people, anybody who's asking me about medication use, I assume everybody is susceptible. And that is because medication overuse headache is so insidious. It creeps up. Like I said, you're taking a medication because it helps you. And so you keep taking it and it keeps helping you. And so it's really hard to see that the medication itself is actually what's causing the problem. And it's really hard when somebody is in medication overuse headache for them to get out of it, largely because of perception. They see that the medication is helping, and so they don't want to stop it. And if this is the only medication they've tried that has helped, then they're distrusting of any other medication that it's going to be as effective. But as pharmacists, I think you have an excellent opportunity. Perhaps I think you're maybe better positioned than any healthcare provider to address medication overuse headache before it happens. You can talk to people if they're coming to you saying, what can I do for my headache? You can talk about these guidelines and the frequency and let people know what they need to watch out for. And if somebody is talking to me and they're telling me that they're taking medication 2 days a week or more, even though they're not quite at these thresholds for the most part, I warn them about medication overuse headache. And honestly, I basically talk to everybody about medication overuse headache, even if they're not having very frequent headache or migraine attacks. And that way they can be prepared. And so they don't actually fall into that insidious trap of medication overuse. Next point. There are some language considerations. Medication overuse headache can be really stigmatizing for people. That idea of overuse makes people feel judged, and they feel like they're being blamed for their headaches. They were just doing what helped. And so I've talked to so many people who are really angry when they're told they have medication overuse headache, or because they feel like they're being blamed for the problem. So I personally use rebound headache. That's because it's what patients use. There's an almost intuitive understanding of what that means. Another potential phrasing is medication adaptation headache. Next slide. I have no way of knowing if I had gone to you when I was a teenager and said, I've got these headaches, and you had made any recommendations, if it could have changed my story. But these three interventions, trigger identification and management, supplements, or any kind of prevention for migraine, and medication overuse headache education, I have seen these three things either individually or in combination utterly change people's lives, a complete transformation to the point where people forget that they ever had an issue with headache or migraine. And so I hope you take the information I shared with you today and change someone's story. In fact, I think you can change many people's stories. Thank you for listening.
Great. Thank you so much, Kerry. It's great to be able to hear from you how your headaches have been and some of the advice that you've provided. We will now move on to our last speaker, Emma Paulino. Emma is a practicing pharmacist at her own community pharmacy in Portugal, and she's general manager of SB, a company that engages community pharmacies in the implementation of patient support programs. She's currently the president of the National Pharmacy Association in Portugal and represents this organization at various international groups, such as the PGEU and FIP. Currently, she's the professional secretary of FIP and thus a member of the Bureau of FIP, and she's previously been chairperson and project coordinator of the Young Pharmacists Group. Extremely active and been a secretary of the community pharmacy section. She's also president of the PCNE, and she has joined the board of directors for the International Primary Care Respiratory Group. Please join me in welcoming Emma Paulino to speak to us about what pharmacists can do. Thank you.
Thank you very much, Parisa, for the kind introduction and for the invitation to present. So I'll be trying to add on what has already been presented by the previous speakers. So I'll try not to duplicate any information, but maybe build on what has been said in terms of what can the pharmacist, and particularly the community pharmacists, do to facilitate the patient journey in this important and prevalent condition. So in the next slide, this is just a short introduction to what headache might feel for people. We've already talked about the important impact of headaches in the community and how impactful it is in terms of quality of life. So it is really important that we are part of the solution for people who really look for more information on self-care, but also the counseling necessary for them to manage the disease. So in the next slide, just briefly mentioning the patient journey and how people might feel in different stages of the experiencing symptoms. I think that what has already been said is very important in that people need, and there is an increasing need and expectation for people who suffer from headaches and migraine to interact with others that experience the same kind of symptoms, so that they can identify themselves with the challenges that they encounter. Because most of the time, and for a lot of people, managing the symptoms is not easy and can have ups and downs in terms of being able to control the symptoms and even identify the triggers and avoid triggers themselves. So I believe that one of the most important things for pharmacists is to be able to empathize with the difficulties of people, identify in which stage of the patient journey the patient is. We have to acknowledge that some solutions that have worked in the past might not be the right solutions going forward, that there might be the need to reevaluate and reassess these solutions. Every time that we have the chance to interact with the person and reassess the person's need and evaluate also what our counseling should be. So it is very important that that we acknowledge that there are different stages and that the people might need different solutions and support over time. In the next slide, just briefly highlighting why the role of the community pharmacist is so important and so prevalent in this case. So we have heard headaches are extremely common. Most headaches present pain that is mild or moderate and lasts from several hours up to a few days, and usually responds well to treatment, and particularly with over-the-counter analgesics such as ibuprofen or even paracetamol. So this is often a situation that people seek the advice of community pharmacists to be able to manage their symptoms. So in the next slide, this is just a picture that shows the flow of patients who seek pharmacy first. And this is the picture that we have included in FIP in our document on community pharmacy as a gateway to care, in that people often self-referral themselves to the community pharmacy because it is somewhere where they could seek rapid advice. They know that they can interact with healthcare professionals directly without appointment. So there is often the visit to community pharmacies around the world. What is important to acknowledge also is that depending on the scope of practice, we may be able to give or to make available different treatment options at the pharmacy, and not always the same. So we do have community pharmacists around the world that are only able to provide OTC medications such as analgesics, but we see an increasing number of countries where, depending on contracts with the health ministry or even health insurers, they can also prescribe certain triptans, for instance, so preventive medicine for migraine, for instance. And we also see some countries where with telemedicine, they can also make a link to directly to the physician, who may then make a diagnosis and prescribe medication that the pharmacist then dispense at the community pharmacy. So what is very important to acknowledge for community pharmacists is that they should be aware of what the scope of practice in their own country is, and adapt the solutions accordingly. And then, of course, adapt the solution to the specific patient's needs that we have. And these may be advice only on self-care and non-pharmacologic treatment solutions. It may involve dispensing short-term treatment with, for instance, OTC medication, but it also might mean a GP referral or a specialist referral if we think that the symptoms that are being presented should reinforce the need of the patient seeking a physician. In the next slide, like I've mentioned, we do have a number of countries where headaches and migraines are considered minor ailments, in which pharmacists can have an increased scope of practice in terms of prescribing the certain medication and handling symptoms directly. So these are a few examples of when that happens in the kind of communication that we see about these services. In the next slide, we start now looking at what the healthcare professionals' journey should be in terms of management of headache in the community. So one of the most important steps is, of course, assessment. And in terms of the assessment methods, there are quite a few, and there are quite a few with mnemonics, so that we can always remember what are the types of information and level of information that we should seek in order to ensure that we are making a right assessment that allows us to either advise the patient directly or refer the patient to another level of care. So we have the some examples here: the AS method or the ENCORE methods, which are already probably known by you, and these are very general assessment methods that can be used for any type of symptoms that are presented. In the next slide, I show another type of assessment form. This one has been created within the initiative from the World Health Organization, Lifting the Burden. And this is specific for headache, and it basically allows the pharmacist to assess the impact of this situation in people's lives, and in terms of the frequency, etc., so that we can then make the right decision in terms of providing care, empowering patients for self-care, or referring the patient to the doctor. And in the next slide, I show a different kind of tool, which is available on the University of Saskatchewan in Canada website. It's from the College of Pharmacy and Nutrition, and basically it's a pharmacist assessment forum for headache and migraine, and it's very complete in that it touches on the points that have already been mentioned by previous speakers, and particularly Kerry, in terms of identifying which kind of pain or possibility in terms of the type of headache we are seeing or interacting with. So there is collection of information on medical history, on drug history, and then a review of symptoms and any red flag warranting emergency room visits, etc. So it's a very complete form which you can access in the like I said, in the website of the College of Pharmacy and Nutrition from the University of Saskatchewan. And this is an example. So in the next slide, one of the most important things is obviously to identify which kind of headache we are dealing with, so because the treatment can be significantly different. So again, in the same document, we see a very interesting table that presents the differences between symptoms that we observe and the frequency and characteristics of the symptoms in migraine versus tension headache. So this is a table that you might use when you are interacting with the person in order to make a differential assessment of the type of headache. And then we move after the assessment, and in the next slide, we are introducing what mostly the pharmacist is being sought for, which is the counseling on the use of medicines. And here, of course, we have to understand which is the best option for the patient. And again, we should ask the patient about their history using medication to ascertain whether certain types of medication are better for certain patients, and it might depend on different factors. So in the next slide, there is, and this is a table from the Kaiser Permanente migraine and tension headache guideline, which is a very interesting document as well, available online. And it talks about pharmacologic options for acute treatment of tension headache. It highlights what kind of medication is not recommended, and then what might be available in your countries and how it should be taken in terms of an initial dose, maximum dose per day. We also have information about relative contraindications. Like I said, the assessment of the patient and the identification of the patient himself is very important. And then special considerations in terms of whether these medications are available in most countries as an OTC or not. So if they are options or not for that specific patient. In the next slide, we have some information about some risk factors for gastrointestinal symptoms. For instance, when using non-steroid medication. And when we are considering this is also important for our choice of medication that we will counsel the patient with. So we know that risk factors like age above 65 years, renal or heart disease, history of ulceration, high dose NSAID combination, and concomitant use of corticosteroids or anticoagulants. For these patients, we should be aware of these risk factors and probably recommend other type of treatment other than non-steroidal medication. We also have to acknowledge that there can be some inappropriate medicines use behavior that we should prevent. And this is particularly important in self-care, so we can ensure that patients do benefit the most from the medicines they are taking. So we have the risk that people are not taking enough analgesic or taking it at the wrong time. Most often people delay the treatment until it's too late in order to prevent more serious headache. So it is important that we counsel the patient on the right time to take an analgesic, and that as soon as possible it should be taken. Using inappropriate analgesics, and this is only an example, codeine, but also other types of medication, and we've talked about rebound headache. So it is very important that we prevent inappropriate use. And always taking OTC analgesics with food. We know that most of us usually continue to give this recommendation. But in fact, this might not be the best solution. Because the faster acting headache relief that results may also help even to eliminate the temptation of taking more analgesic, which can then prevent the risk of adverse events. So it really depends on the medication and the risk factors for the person. So in the next slide, we've talked a lot about triggers, so I will not go into detail, but we have to acknowledge that they exist, and we have to help people to understand which ones they work for them. And the use of apps, like it was already mentioned, can be a good and useful tool to understand the relationship between some kind of behaviors, for instance, or some kind of environment, and also the occurrence of headache. In the next slide, more importantly, are some self-care strategies that we should recommend, which are related to some of these triggers, and that we should really advise the patient about following these self-care strategies: eating regular meals, resting sufficiently, taking up regular exercise, staying hydrated, limiting caffeine intake, limiting the use of OTC pain medicines, and stress, which can be addressed by modifying the behavior and through meditation, relaxation exercises, use of apps, etc. This has already been mentioned here, but it's not too much to stress the importance of community pharmacists when they are dispensing the medication, that they should also advise on these self-care strategies. Almost finalizing. So we have the situation where we might need to make a referral. It is possible if the patient is not responding to treatment, or if any of the red flags appear. So, and this is a mnemonic again for red flag warning signs in headaches. So if it's systemic, if it's, and here we have the conditions that could present themselves through headaches. Some signs, tail signs like fever, sweats, rash, weight loss that accompany headaches. Some neurologic symptoms and signs as well that we should refer patients to the physician. Onset, which is very sudden. Patients who are older than 50 years, and a pattern change in terms of the characteristics of the pain itself. So these are red flags for referral, and these are actually included in some of the assessment forms as well that I mentioned before. To finalize, role of pharmacists, which are the critical aspects. Communication skills. Can you click on the next? Yeah, thank you. So we have to develop our communication skills and be able to ask the questions so that we get full information that can help us help the patient. And for this, motivational interviewing, for instance, can be an important tactic. Also follow-up. So some of the assessment forms that I mentioned include, for instance, telephone follow-up after a few days to understand whether symptoms have subsided. And I think that when we are when it is possible, that these follow-up can be very important and differentiate our service with our patients. So in the next slide, cooperation and with other healthcare professionals, and of course, collecting evidence. And we've already mentioned that in previous speakers about the importance of real-world data, and that this can help them have better treatment options and flows for patients everywhere. As a conclusion, so we know that according to the WHO, and in the next slide, we know that educating people with headache about how to treat their headaches effectively and efficiently is of considerable public health importance. Obviously, we believe that community pharmacies have a key role to play because pharmacy staff are the health professionals most likely to have contact with people suffering from headaches. To support pharmacy staff in this role, of course, we need training, and this is one of the initiatives by FIP towards that. We have to ask the right questions, provide appropriate treatment advice. This obviously helps to maximize the potential benefit of analgesics in the treatment of headaches and to reduce the burden of headaches overall. So, and this was my last slide. Thank you very much again for the invitation, and thank you for listening.
Thank you very much, Emma. That was great to hear about all the roles and responsibilities of pharmacists when it comes to headaches. So now it's time for some questions to our panel. If I may get the panel. Okay, brilliant. So our first question is for Professor Goadsby, and I guess you were expecting something like this, but as we all know, the vaccines that are used for COVID-19, as a side effect, they tend to give headaches. And one of our questions is, could you explain why we're getting headaches from the COVID-19 vaccine?
Well, the first thing to say is that headache with vaccines is not novel to COVID vaccines. It's a well-reported phenomenon. The Americans have something called the Vaccine Adverse Event Reporting System, and you can dig through that and find out that they've got 30 years of data, that headache with vaccines is not a 21st century problem. It's very well recorded. The rates. If you look at the rate differential between placebo in the clinical trials and active treatment, it's about 10 to 12%, which is a little bit more than what's on average reported in this VAER reporting system, but not stunningly so. So the first thing I'd say is that in the broad sense of things, the COVID vaccines behave more or less like vaccines do. The vaccines produce headache. So the underlying question is, why do any vaccines produce headache? And I want to make that point because there's nothing dangerous, crazy, or unusual about COVID vaccines. Why do vaccines in general produce headache? Probably, I'm going to say because of immune activation. I think in patients with migraine, it's simply a matter of perturbation. If you have a change in physiology, a proportion of people will get headache, and that proportion are not surprisingly people who have underlying migraine biology. So I think it's a broad phenomenon of activating the immune system, and it happens with headache is common in upper respiratory tract infections. Headache is very common if you perturbate your physiology, and vaccines perturbate the physiology in a directed sense. So I think it is really important to recognise that the COVID vaccines are not sort of standout weird vaccines. This is it's normal in the sense of what to expect.
Right. Thank you very much. Our next question is for Kerry Smart, and the question is around, I guess, your experience of your headache and the duration that you've suffered from headaches. If you look back, is there a time when you think you should have had earlier pain management or different pain management? And would anything have made a difference from your point of view to the way your headaches have progressed?
So for me, in retrospect, I've actually had chronic migraine probably since I was 11, and I tried to get help. My parents took me to doctors. I saw the student nurse a lot. But this was in the early 90s. My head pain is on both sides. I don't have a visual aura. And so I don't think that at that time, healthcare providers were looking for my presentation of migraine. And what I had talked about as headaches actually got worse when I was in college. So about 20, when I was about 20, and I did try to get care. And I had been dismissed by healthcare providers for so long. I was basically self-treating in like self-referring. So seeing a dentist, thinking it was my jaw, seeing an ENT, that kind of thing. And so I do think if I had been diagnosed and given a preventive when the issue started, or 5 years in, or even 10 years in, it could have definitely made a difference. Which is why it was really exciting to think about the things that pharmacists could do to help. And it was also kind of sad to realize it could have made a huge difference in my life. And it just, the information wasn't available to me.
Thank you. Kerry, Emma, based on Kerry's response, if you had to think about how pharmacists could get involved in public health education around headaches, what are some opportunities that pharmacists have, not within their practice, but outside their practice in terms of public health education around headaches?
Well, this is an interesting question also because we, in Portugal, the patient organization for migraine patients, the president is actually a pharmacist. So she's been quite involved in that patient organization as a patient herself who suffers from migraines and doing a lot of health campaigns and increasing awareness of the burden of migraine with the different healthcare professionals. And one thing that she also that they also did was to establish a helpline for patients to call, and it's staffed by a pharmacist. So the pharmacist is providing advice through that helpline and counseling. So there are many ways that pharmacists can participate, obviously through community pharmacies, again, due to our presence in the community, the fact that we are very visible to the public. We are in the high street, so through our windows, in our premises, we can definitely participate in campaigns that bring awareness to the overall population about the burden of headaches in the community, and referring people to the right level of care. So I do think that there are several roles for pharmacists that are not limited to the advice on medication only, but also the involvement in this kind of for instance.
Great. Thank you, Emma. Professor Goadsby, we have a question for you around, I guess, headaches that women tend to get. You know, you get headaches with dysmenorrhea, you get headaches as you're going through menopause, and headaches for all sorts of other triggers, but specifically looking at these, maybe the hormonal triggers for headaches. Can you explain whether there is a reason to do with dysmenorrhea and whether there is a reason to do with menopause and how these affect headaches?
Yes, it's well recognised, as you say, that females are more prone to headache than males. It's well established in migraine. There are 3 females for every male, more or less. And it's true that the male-female ratios are about equal in childhood and picks up in favour of women when they start to menstruate, and tends to tail off quite significantly after the completion of menopause. I'll return to a theme of change. For menopause, it's relatively easy to conceptualise that as cycling changes, in particular in the brain, the hypothalamic pituitary axis cycling changes, then that instability and variation seems to increase the proneness of women during their menopause for for migraine. The upside to that is that when it's all finished, generally speaking, in the generality of things, like the 80% rule, is it will settle down altogether after a slightly rough ride through the menopause. So I think that's physiological change. Certainly, headache associated with menses themselves is again a well-recognised phenomenon, typically in the 2 or 3 days before the beginning of the period, and sometimes in the day after. And they're particular situations where analgesics can be quite helpful, particularly if you able to use them in those couple of days beforehand. Both of the themes of that are physiological change, largely driven by estrogen change, that triggers the susceptible person, migraineur, to have a activation of their attacks.
Great, thank you very much. So our next question is around the overuse of medications, I guess the disorder around overuse of medications and headaches. And this question is for the panel as a whole, and it's really looking at different perspectives. One perspective to Professor Goadsby is, well, how can you get someone off the medications and treat this disorder issue? And to Kerry, it's around, well, from the advice as a patient advocate, how can someone actually figure out that there is an issue? And from a pharmacist's point of view, how can you prevent this happening in the first place when we're selling analgesics?
Well, for myself,
yeah.
Sorry, I'm sorry to interrupt you. It's the delay.
That's okay. No, go ahead.
Yeah. Well, for myself, I wish I was in the pharmacist's shoes in this way. It's stopping it before it gets started is a much better way than trying to stop it when it's already started. The people who are in, physicians who are in headache practice have this discussion almost every day they practice. What do you do? I think that it a little bit depends on culture, I have to say that. In some cultures, you can say you must stop. And that seems to, I'm told, in some cultures, that's a reliable strategy. Where I've worked, it's not such a reliable strategy. It's a bit difficult, because if you say to someone you must stop doing this, as Kerry was saying in the presentation, they're not doing it because they're crazy, and they're not doing it for recreation or entertainment. They're doing it because they're trying to function. They've recognised an association between taking a medicine and having some level of better quality of life. So you have to, when you start to have this conversation, you have to recognise that just for many people, just stopping and sucking it up, so to speak, is not a very practical solution. It doesn't help them very much, and certainly anyone around them are going to know what's going on. I think that the needle's moved a lot in practice in this. If we'd have had this conversation 15 years ago, most people wanted to advocate reduction before beginning prevention. If you've got 15 days or more of headache, then you're a good candidate for a preventive. I think that the pendulum has swung to suggest that a reasonable way to start with medication overuse problems is first to explain them. I mean, if someone understands why you're going on about this, that the use of these medicines may be making things worse, it's helpful because they want to have a buy-in to what's going on. In the general terms, most of us, I think, now would start a preventive medicine and encourage person to reduce whatever the overused medication is, and try and provide something else to do when the attack invariably comes along. I think that if that doesn't work in practice, and it in the main does, then moving to withdrawal treatment strategies are associated with hospitalisation are sometimes necessary. I think the key thing is to make sure a person understands what's going on. People aren't crazy. Headache patients are not silly. They're simply plagued by a serious problem. And so if they understand why they're doing something, they're getting them to gradually reduce their medicine, go on a preventive, can be careful about their lifestyle. I think that works. But just telling people like a diktat that you should stop, I don't think that's a very bad idea.
Great. Thank you so much. May I pass on to Kerry, please?
It's really hard to know. Like I use the word insidious. You just sort of slide into it. And once you're in it, some people notice that their headache or migraine attacks are getting worse. I think that's generally when I've seen people seek treatment, is because they're taking this medication and it helps, but there's still a problem. But it's really hard to know because it does still seem like it's helping. And I've had people say, well, it can't be medication overuse headache because I'm not susceptible to that, or that doesn't exist, or this works, therefore it can't be medication overuse headache. And so it's really hard to tell. I wish I had a better answer than that. But even when somebody is told that that might be what's going on, there's still resistance because it does help. I did want to mention Dr. Goadsby suggested prevention, and that's actually, I have been in medication overuse headache. I got there by working with my headache specialist. We actually decided I should use triptans twice a day. And then I was using a preventive that was kind of helping, but not as much. And he actually said, he asked me if he thought I had medication overuse headache. And I said no. And then I happened to see another headache specialist a week later because of insurance. And she was adamant that I had medication overuse headache. And I said no. And then about 3 days later, I thought, maybe I have medication overuse headache, and realized the only way to tell was to stop the medication. And in fact, I did. And my preventive worked much better after I stopped it. And it didn't take very long. It was only in a few days. But I think really the only way to tell for sure is if you stop the medication. And even then, some people don't believe it.
Great. Thank you, Kerry. Emma, how can we prevent it as pharmacists?
Well, in terms of preventing, is to give appropriate advice when we are counseling medication for headaches. So I think that we can prevent overuse if we establish a treatment plan for the patient and assist the patient in understanding the appropriate use of the medication. So this is one way that we can prevent. As for when it occurs, I think that it is important to manage expectations and to advise that in most cases it may take up to 5 to 6 weeks to resolve this issue, and most possibly tapering may be required. And there are certain guidelines saying that we should stop all acute headache medications and then start a prophylactic medication. So it's there are a few strategies to address this. The first one, as was mentioned, is that the person themselves acknowledge that this is something they are suffering, and then work with their healthcare professional to try to manage the symptoms of withdrawal to ensure that then they enter into a cycle where medication starts again being effective. But to prevent, I think that the advice given primarily by the pharmacist with an appropriate treatment plan can be very important.
Great, thank you very much. So we have another question for Professor Goadsby. This is around the symptoms that children could present in a pharmacy if they have migraines. So I guess headache is not always the only symptom. What other symptoms should we as pharmacists be watching out for when we get pediatric patients presenting with migraines?
Yeah, that's tricky because they're all diagnoses of exclusion. So there's a vomiting syndrome, there's an abdominal pain syndrome, there's a vertigo, dizziness syndrome, and they typically occur in people in patients whose mum or dad have got migraine because it's an inherited problem, and they they come and they go and they leave no other marker. I think if you think someone's got a migraine basis for that, they really have to get evaluated, because even in good hands, that's a bit of a tricky diagnosis. So I wouldn't be spraying it around too easily. It's a reasonable thing to raise an awareness of the possibility to the parent and suggest that they seek advice about it.
Right. Thank you very much. So, Kerry, we have a question around how well people maintain diaries. So you gave some tips around, some of the bare minimum information to give. What advice could we, I guess, as pharmacists provide to encourage people to keep those diaries? And how long should they be keeping diaries in order to figure out what's causing their headaches or migraines?
That's a great question. My basic advice is to keep it as simple as possible, because the more detail you get into, the harder it is to remember to do it, the more of a burden it can be. Apps can be super helpful. They're not particularly helpful for me, so I can't give specific suggestions on apps, but because they guide the person through questions, that can be easier than trying to remember which things to write down. And as far as duration, it really depends on the person. It depends on the frequency of the headache, because it's how much data can you get. And so for some people, I've seen, honestly, a week or two of keeping a headache diary make a difference. Usually it's a few months. And it can be, when I talked about suspected triggers, it can be that somebody keeps a diary for 3 months on a particular suspected trigger, decide that's not a trigger, then they need to start again. I know a lot of people who actually just keep headache diaries for years because they like having the data. So I would say generally about a few months is a good guideline for getting the information.
Great, thank you very much. And I guess from Emma and Peter's experience, how accurate and how useful are the patient diaries in being able to identify people that need some help?
They are very useful, in fact, because there's always a memory bias when we are talking to people and seeking their advice, their information about symptoms. So a diary helps us really know what the history is, so we don't have that memory bias from people interfering with the information, and the information that is collected can make a difference between us continuing to encourage people to self-care or us advising continuing OTC medication and, for instance, refer to the physician, or even continuing filling the prescriptions as usual or referring to the doctor for a further evaluation. So in fact, diaries are extremely helpful because they help us avoid that memory bias and give our counseling in a more objective way.
Great, thank you. Professor Goseby, do you have anything further to add? I know we're pretty much close to end.
Well, just to say that it's obvious from the global data that headache problems, disabling headache problems, are pitching up to pharmacy. Small improvements in what pharmacists want to do and can do and would do will make a very big difference to the global burden of headache wherever you are. So I'd encourage pharmacists to just take a bit of an interest in this, because there's an enormous amount of good that can be done.
Great, thank you very much. So we have reached the end of this session now. And just as a quick thanks to Emma Paulino, Peter Goseby and Kerry Smart for the excellent presentations and for answering all the questions that have come up. And questions are still continuing to come up, but I'm sorry we won't have time to ask anything further. If we can go to the next slide, Anakin. So just a reminder before everyone switches off that it's World Pharmacists Day on the 25th of September. And it's the 11th year of it. So here's an opportunity to celebrate, and here's an opportunity to be used for public health promotion and campaigns around what pharmacists can do. And if you're stuck for promotion ideas, well, health headaches is a critical one that we can definitely tackle this year and beyond. And finally, please keep in touch with all our FIP events, and that's on the next slide, events.fip.org. So once again, thank you to our speakers, and thank you to everyone, to nearly 300 people who participated in the webinar today. Thank you.